So I'm gonna go over what is macular degeneration first, and then the importance of stabilize the vision, and what are the treatment options for both dry and wet macular degeneration, and then what's in the future, what's in the pipeline, what's coming up in the next few years. And first of all, I have no financial disclosure. So we use our eye as a camera. And then, there's so many different ways for us not to be able to see very clearly. A lot of people say, why don't you just give me a pair of glasses? But it's not that simple, especially for macular diseases. It cannot be fixed with glasses because it's not a refraction problem. It's actually a structural problem. So what is macula? Macula is the center of the retina. Just think about like an eyeball. If the wallpaper of the eyeball is the retina, and right in the center, that's the macula. The macula is very small. It's only like about 500 microns, very, very tiny, but it's extremely important for our central vision. So as you can see, right in the middle is our central vision. It's controlled by our macula. And then outside of that, those are peripheral visions. So with patients with a severe macular degeneration, they lose their central vision. However, they usually they're not totally blind because of their peripheral vision is still preserved. So a lot of times, the contrast sensitivity goes down first before they lose the vision. What is contrast sensitivity? Usually, we don't know much about it, but think about it. What's the highest contrast? Is black versus white. So when you have a very high contrast, patient with macular degeneration can see pretty well. But once we start to blur down those contrasts, and then the vision start to go down, so they don't see as well. As you can see, when they have a decreased contrast sensitivity, everything is in the fog. They can't see. This is a picture with patient. This is a very, very high contrast sensitivity. So as you can see, everything is so nice and sharp. When we reduce the contrast sensitivity, everything becomes blurry and blurrier to the point they can't see very well. Lighting is extremely crucial in patients with macular degeneration. They need a lot of time. Patient will say, I can't see when it's not very bright, and then I need so much light to see better. That's because they have decreased contrast sensitivity. So the lighting will bring up the contrast sensitivity. See, in the low light condition, everything's much more blurrier compared to bright light. And a lot of times the patient will come to the office, and then when we ask them to read from the chart, they can see 20/20. However, the quality of 20/20 is very different from the normal people. In the low light condition, they can barely make out those letters. Yes, they can see them, but they're not very clear. So even though at 20/20, the quality is very, very poor. And they can have distortion, even though they can make out the F, E, L, O, P, Z, D. However, those letters are distorted. So how do we examine patients' eyes? If you've been to the clinic, you will know we use a device called slit lamp. Slit lamp is a microscope. It can magnify all the structures. So we can see all the small tiny vessels in the retina, the optic nerve very clearly. And then we use imaging devices to take pictures. So this is a wide field imaging from this photo. As you can see the optic nerve, or the vessel coming out of optic nerve. And this is the macula I'm talking about. Look at this, a tiny little region is responsible for 100% of your central vision. Anything outside those big vessels, those are the peripheral visions that you have, even though area of the retina is so much bigger. So what are the most important structures in the macular region? There are 3 layers that's extremely important for the macular health. The retina, the foundation of the retina, which is called RPE. So it supplies a nutrient to the retina. and the blood supply underneath the RP, the choroid. So if you ever come to our clinic, a lot of time you will get OCT. So OCT is optical coherence tomography. What it does is very similar to ultrasound. Instead of ultrasound is using the sound wave, OCT uses a light wave to construct a 2D images of your retina. Take a look at here. This is the picture of this retina, and here is the optic nerve. You see a little divot. This divot is called fovea. Fovea is the center of the macula. So, what's the difference between dry and wet macular degeneration? The dry ones, as you can see, the foundation is being damaged. There's a structural damage to your house. And then when it's wet, that means it's being flooded. So it's leaking, it's bleeding inside the eye. So the foundation maintenance is extremely important. We want to maintain the vision before they go bad. This is a picture of small drusen. Those are very early changes in the macula. Those are little tiny yellow dots. So what are they? Those are proteinaceous deposits underneath the retina. So why do we have them? Think about the RPE cells underneath the photoreceptors. Those are the scavenger cells. They get rid of all the waste products in our eyes. And then we only have one set of scavenger cells in our entire life. As all our cells, they get older. So they start working very slowly. And then they can't get rid of all the waste product. Then they start to accumulate. So that's why it's age related. So the young people, they have very good scavenger cells. They don't accumulate those waste product. That's why you don't see it in young patients. And then we only start seeing those drusens if it's age related. It has to be a patient above age 55. As we start to accumulate more drusens, as you can see, now it's become very obvious. Those are intermediate and large fluffy drusens. When we see intermediate and large fluffy drusens in the macula, you have an increased risk to going into wet macular degeneration. So this is the OCT of the normal macula. As you can see, nice little divot. All the RPE cells, photoreceptors are completely straight. Take a look at the patient with like an intermediate macular degeneration with all the drusens. There's a distortion of the RPE cells and the photoreceptor. That's why patient has complaining of distortion. So the straight line become distorted. They're not straight, it's very bumpy. So this is a picture with a wet macular degeneration. As I mentioned earlier, wet means it's either bleeding or leaking fluid within the retinal tissue. As you can see in this picture, there's blood over here, here, and here. And then the central macula is thickened. It's kind of yellowish. Once again, compared to the normal OCT, you can see there's subretinal fluid, there's intraretinal fluid over here, and there's some scarring start to form. Patient has very distorted blurred vision. So this is a picture of advanced dry macular degeneration. You can see that this whole area doesn't have normal tissue. The tissue become very atrophic, very thinned out. So the normal retinal tissue is gone. What you're seeing is a choroidal tissue. The choroidal is the tissue underneath the retina. So there's no more retinal tissue. So patient has a huge blind spot in their central vision. As you can see from here to here, there's complete obliteration of the photoreceptor. They're completely gone. So for the age-related macular degeneration progression, they usually start with the small drusens, like asymptomatic, very mild changes. And then when the drusen become bigger, patient becomes more symptomatic. They start to complain about decreased vision, blurred vision, distorted vision. And then they can go into two stages, in the advanced dry stages, or can convert into the wet stages. So managing the dry macular degeneration. So what can we do? There are certain preventable prevention that we can do, modifiable or unmodifiable. Modifiable is something that we can do to help us, such as stop smoking, control our blood pressure, control the cholesterol, and then control the cardiovascular diseases. The unmodifiable risk factors are family history. So if you have family history, of course, you have increased risk developing macular degeneration, and hyperopia, light iris color, and female. So usually the dry macular degeneration is very slowly progressive. A lot of patients are completely asymptomatic. As they progress into the wet macular degeneration, what can we do? Currently, the treatment modality is usually the injections, and we have 4 different medications to choose from, and I will talk about it later. And laser. Laser is not very popular anymore because it does cause a central scotoma and it destroys central vision. So we only do it as a last resort, and it's not the thermal laser. We should use a PDT, photodynamic therapy. So as I said, dry macular degeneration is the most prevalent ones. And then usually 80% of patients with macular degeneration have dry type. They're very slowly progressive. So majority of those patients don't really have much symptoms. And rarely they have progressed to advanced disease with severe vision loss. So everybody heard about eye vitamins. The age-related eye diseases and concluded that there's certain vitamins are good for our eye health. Things including lutein, zeaxanthin, vitamin C, vitamin E, and zinc. Copper is not really needed. The reason we're using copper is because if you take high dose of zinc, you can become anemic. So copper can prevent that. So that's why copper was added to the formulation. So do they really work? Why are we pushing vitamins? From the average study we have shown that the risk of progressing to advanced macular degeneration can be reduced by 25% over the 5-year period. So they do work. However, a lot of patients don't know that when you have a very early mild diseases, there's no benefit by taking the vitamins. So the vitamins is only beneficial for patients with moderate to severe diseases. So far, with patients with a severe dry macular degeneration, we don't have any treatment modality. We can only push vitamins for all the patients. However, recently there are 2 clinical trials going on to try to slow down the progression of geographic atrophy, which is the severe form of dry macular degeneration. As we know, inflammation is bad for our macular health. So the complement cascade causes a lot of inflammatory response. So the researchers have studied for those complement inhibitors to see if we inject those inhibitors into patients' eyes, do they slow down the progression of the geographic atrophy? So this study is already in the phase 2/phase 3 phase. So, and the result is pretty impressive. They total have 286 participants with patient with geographic atrophy secondary to age-related macular degeneration. The outcome measure is by the baseline, 6 month and month 12. We use the auto fluorescence photos and to measure out the size of the geographic atrophy over the next 12 months. So patient receive monthly injection in the study group. And then there's earlier, the one I mentioned is a complement 5 inhibitor. There's another complement 3 inhibitor. It's also in clinical trial. Currently, it's in phase 2. And then we are actively recruiting patients in this trial. And then that trial is also monthly injections. So in the past, we never treated with a dry macular degeneration with injection, but in the previous those 2 trials, we do inject the patient monthly to see if we can slow down the geographic atrophy formation and expansion. So what are the treatment modalities for wet macular degeneration? So everybody knows about injections, like a wet macular degeneration, you go to the doctor's office, you get a shot in the eye. So there are 4 different medications that we have commercially available for us. And then if everything fails, we can also use a photodynamic therapy to treat a patient. Avastin is the first anti-VEGF came out on the market. Actually, initially it was designed for colon cancer. However, it didn't work very well for colon cancer, but works very well for eye diseases. So about, I would say 16 years ago, AL published a study. It was like it had amazing results to control the wet macular degeneration. Prior to that study, there's nothing that we can do for the wet macular degeneration. We'll just tell the patient, you have fluid in your eyes, you're bleeding, but there's nothing that we can do. But about 16 years ago, finally, we'll have something that we can use to treat macular degeneration. Lucentis is made by same company as Avastin. It's also made by Genentech. So what's the difference between Lucentis and Avastin? Think about it as Avastin as a whole molecule. Lucentis is just cleaved into half. So you have a half of the Avastin molecules. So theoretically, it's smaller. So maybe it can penetrate deeper in the retina, so it work more efficiently. But so far, head-to-head studies didn't show the difference. They both work equally well. And Eylea came out 2 years after Lucentis was in the market. So it worked a little differently. So previously, Avastin and Lucentis, they are monoclonal antibodies against the VEGF. So VEGF is the signal promoting vessel growth. And Lucentis and Avastin, those are antibody against the signal. So it targets the signal. But Eylea, what it does is doesn't target the signal. It targets the receptor. So the signal cannot attach to the receptor to causing the chemical reaction. So they work the same at the end, but they target different endpoint. Beovu is the newest one came to the market. It came to the market about like a year and a half ago. However, it was not being used widely. In the clinical trial, it worked wonderfully. You know, like some patients still being wet after, despite monthly injection of Avastin or Eylea or Lucentis. With Beovu, they dried up beautifully. However, the safety profile is not very good so far with Beovu, so that's why it's not widely being used. Some patients develop severe vein occlusion and causing devastating vision loss. So that's why we're still waiting for the safety profile to improve before we can use it on the patient. So when everything fails, patients still have progressive diseases, what do? We can offer them photodynamic treatment. So what it does is and this is a laser treatment, it's a cold laser. What we do is we actually have to set up an IV, have a nurse set up an IV, inject the medication through the vein, and then let it circulate through the vessels, and then apply the laser. It works really well in the past for patients with severe disease. However, it does cause macular atrophy over time. So we try to use it as a last resort when all the injection doesn't work, then use it, because we don't want a patient to have any collateral damage from the photodynamic therapy. So what do patients with macular degeneration can expect? Please don't lose hope. There's so many new medications coming out on the market recently, and then a lot of clinical trials is targeting towards the dry macular degeneration. So we're living in a time of innovation. There's so many new things are coming up. For example, stem cell research. And then my colleague, Dr. Clarkson, is the world's expert of stem cell research. And then he's going to talk about how stem cells can help you to slow down progression of the geographic atrophy or potentially treat macular degeneration. So I'm going to turn the podium to Dr. Clausen.